Start the recording now. Exactly. Hi, and thank you everyone for joining today's webinar. Today we're going to have a Q&A webinar where we're kind of going to focus on compulsions. I'm going to talk more about that shortly, but obviously you can ask any and each question that might come into mind during the webinar, or that you brought with you. It doesn't have to be about compulsions. That's just the general headline for our webinar. And we actually have quite a few interesting questions that were pre-submitted. Now, I just want to say, I see someone raising their hand. It's a little bit difficult in this format to relate to raised hands. So whatever is on your mind, please write that down in the Q&A section. Even if you have follow-up questions, just write it down there, and then I'm gonna relate to all of it. Let me just quickly, I have my window open here and it's too loud. 1 second. It's much better. All right. So as I mentioned, we have quite a lot of pre-submitted questions, and I'm gonna try to go through those and then also relate to questions that you can write down here in the Q&A section at the same time. All right. So without further ado, let me just give you a quick definition of what compulsions are. So as some of you may have already learned, in OCD, we talk about the cycle of OCD. So you have a trigger that might be, for example, seeing a doorknob, a very classic example. And then an intrusive thought comes up. What if there are some kind of germs or viruses or bacteria on this doorknob? That's what we call an intrusive thought, a thought that you don't really want to have, but that comes up anyways. That creates distress. And then we do something to reduce that distress. And that's what we call the compulsion. And the compulsion leads to short-term relief, but in the long run, it causes problems, right? And compulsions can be all kinds of different things. So example, we have behavioral compulsions, which would be, for example, I touch the doorknobs and then I have to wash my hands frequently. Mental compulsions, I touch the doorknobs and then mentally maybe go through statistics and try to prove to myself that nothing's going to happen. Or if touching the doorknob left some kind of icky feeling within myself, then I can try to neutralize it with mental rituals, mental compulsions. Reassurance seeking, asking someone around you, wait, nothing's going to happen because I touched the doorknob, right? No chance I'm going to be contaminated now. Avoidance, not touching the doorknob at all. And then accommodation. Accommodation is like kind of type of compulsion where you make the people around you do the compulsion. It's very common with children who suffer from OCD, but also if you have a partner or a family, which would mean that, for example, nobody in your household or your partner is also not allowed to touch the doorknob or also has to wash their hands 5 times afterwards. So kind of including people around you into your compulsions. Actually, accommodation is a big topic that we might do a dedicated webinar about in the future, because we've gotten a lot of requests about that, but I'm going to cover it a little bit today as well. Wait, where did my question tab go? There it is. Okay. Second. So let's start with some of the pre-submitted questions. I have intrusive thoughts around my relationship with my partner. I'm afraid we aren't a good match and don't know how to be 100% sure. I don't think I'm doing any compulsions though. Is it still OCD then? Um, okay, that's an excellent question. First of all, having intrusive thoughts around your relationship or whether your partner is the right fit for you or whether you are in love, that's what we call relationship OCD, ROCD. A kind of subtype of OCD that is, at least in my opinion, becoming more and more common, specifically because we have this illusion that there is an endless pool of options when it comes to our partner and that we have to find the perfect one, which is usually not a realistic place to come from. Um, anyway, so that would be the subtype, but like there's some subtypes where it's a little more tricky or difficult to identify the compulsions. Um, and although there are, even in the diagnostic manuals, we have the option to diagnose OCD that has no compulsive behavior. I have to say, in my clinical practice, it hasn't happened yet that we haven't found any compulsions because the whole cycle doesn't work. If we were to just react to intrusive thoughts as if they were like any other thought, wouldn't give it any more meaning, wouldn't do anything about it, then they wouldn't torture us. It wouldn't be OCD, right? So there's always, usually we always find some compulsions, but it's not always something you do. It's not always something specific, some mental picture that you bring up to reduce the distress, or not always outward directed reassurance seeking. Sometimes it's much smaller than that. Sometimes it's just the amount of attention that you pay the intrusive thought. In fact, any kind of additional attention, rumination, trying to figure out something can be a ritual as well. So, wait, what? Right. So, for example, I am afraid we aren't a good match. So you might look at your partner and the intrusive thought comes up like, well, are we a good match? Right? And then you don't do any obvious compulsion, but you might get stuck with this thought. You might think about, go back through past situations, might build a pro and con list in your mind. You might think, what does that say about me that I'm staying in a relationship where I'm not 100% sure? So any kind of extra mental capacity that you invest into this thought can be considered a ritual. Obviously, those kinds of rituals are a little bit harder to break. I mean, with the behavioral rituals, it's always very obvious. Just don't do them. With the mental ones, it's a little harder. Of like, okay, what? But how do I not pay attention to the thought? Because I'm also not supposed to suppress the thought, right? And one metaphor that I read about, I think his name is Michael Greenberg, that talks a lot about how rumination and all of those things can be compulsions. One metaphor that I really like is the fly metaphor. It's imagining that the intrusive thought is a fly and it lands on your hand or somewhere on your body and it's uncomfortable. You don't want to have it, right? Nobody wants to have a fly on their body. And then any sort of like thinking about it, trying to solve the puzzle, trying to understand whether the thought is right or wrong is kind of like doing like this, like you're keeping the fly. So instead, you want the intrusive thought to be there. You also don't want to like, try to like make it go away because as you know, flies come back. So you just want to leave it there, but put your focus on your life, right? If the thought comes up, it's bothering you, right? It's annoying. It's right there, but you don't pay it any further attention. You could kind of just direct your attention towards whatever you were doing before that. And the thought is still there, and you might still be aware of it, right? You don't want to push it away. The fly is there. You're just gonna direct your attention elsewhere, and then possibly eventually the fly will go away. It's uncomfortable, it's hard, right? You constantly want to go back to the fly, you want to make it go away, it's tickling you, it's annoying, it might be disgusting. But what you do instead is just you think about, okay, what was I doing before the intrusive thought came up? And then you go back to that. Was I just having a conversation? Was I just cooking? Um, and let the intrusive thought be there and let it pass, just like most thoughts will pass eventually. That was a super long answer. Let's see if I can make the other ones slightly shorter. Is it still considered a compulsion if I only ask for reassurance internally, like trying to convince myself I'm a good person? Um, yes, absolutely. As I just mentioned, any kind of attention that I direct towards my intrusive thoughts are considered a compulsion. Another way to look at it is the intrusive thought comes up, it creates distress. Anything that helps you reduce the stress in the short term is considered a compulsion. Or any way where the intrusive thought comes up and you give it some kind of meaning, you take it seriously to a certain degree, then you're already on your way to performing a compulsion. So in like, years ago when we knew less about OCD, the definition of what a compulsion is was much more directed towards the obvious. And the more, at least I learn, and I think the more that research develops, the more we understand how intricate, how difficult to catch those compulsions actually are. But as I mentioned before, if you have intrusive thoughts, if they come back again and again, and if there's some part of you who takes those thoughts seriously to a certain degree, then you will probably also find some kind of compulsion. Okay. I have severe OCD, for example, scrupulosity, social fears, plus many more themes, and symptoms of borderline personality disorder. No life-threatening behaviors, but relationship, emotions, and sense of self issues, and symptoms of avoidant personality disorder. Do you know what should be treated first, or should all of them be treated simultaneously? ERP alone hasn't been helpful enough. Okay. Um, First of all, that's quite a bundle of things to have to cope with. And I'm happy you are looking for ways to find help. I'm happy you tried ERP. The fact that it doesn't work once doesn't mean that it's never gonna work for you. Um, just for those of you who don't know what all of those things mean. So first of all, we have OCD, we have, I think, social anxiety, yeah, social fears, and then we have two types of possible types of personality disorders. Borderline personality disorders may be something that you've heard before. It means that a person experiences quite intense emotions that can come out impulsively in the shape of anger. Sometimes the emotions can even feel so overwhelming that it leads to self-harming behavior, which I think this person said she doesn't have or he doesn't have. They don't have. Um, it leads to kind of shaky sense of self and who you are, and also really impacts your ability to create stable relationships. There is usually a very strong fear of abandonment that leads to behaviors in the relationship that actually, in the long run, damage the relationship and make this fear of being left come true sometimes. And then we have avoidant personality disorder, which is kind of sometimes related to social anxiety. It means that there is an extreme social inhibition. Social situations are very, very difficult. There are feelings of inadequacy, a high level of sensitivity to rejection or criticism. Yeah, and that obviously leads to a lot of avoidance of social situations, although actually the wish to have social interactions and relationships is still there. The difference between personality disorders and, for example, OCD or depression or anxiety is that a personality disorder is supposed to be something that will stick with you for the rest of your life. It's usually the expectation is not that we can heal or make the personality disorder go away. When it comes to borderline personality disorder, there is a discussion going on whether that definition of just defining it as a personality disorder is maybe wrong. Maybe it's really a disorder that, breaks out at some point and can also be healed. But for all of the other ones, that's basically the definition of what a personality disorder is, that it affects you consistently. That doesn't mean you can't you can't learn to manage your symptoms or do anything about it. It just means it's not like a depressive episode, that breaks out and goes away. Um, Obviously, I don't have all the information to really say what should be treated first. There is sometimes, it's very common to have comorbid disorders, which means co-occurring disorders. For example, it's very common to have social anxiety and depression. And then if you, for example, can really point out, okay, the social anxiety was there first, and then the isolation, the loss of relationships, the loss of feelings of self-worth led to the depression, then you can actually say, okay, well, let's treat the social anxiety, because if that gets better, the depression will also go away. So then you can find a clear order. For this example, I find it much more complicated. There is a high likelihood that the OCD somehow will get its claws into those or maybe that, no, I didn't say that right, that the personality disorders and the symptoms are a fertile ground for the OCD to set its roots, and that they are kind of interconnected. So it sounds like you need a holistic approach, someone who knows to do ERP exposure with response prevention, which is the most effective way to treat OCD, as well as also knows how to approach personality disorders and how to relate to the conflicts that those create, and kind of slowly approach all of them, because my feeling would be that they are interconnected and that you can't just tackle one, or that if you try to tackle one, you will obviously get into the other ones as well. Yeah, so this is also definitely a case where I would recommend therapy, and possibly if you feel like the OCD is also severe, also medication. Okay. Is avoidance always a compulsion, or can it be a coping strategy in some cases? So probably generally, most cases of avoidance, I would say, are probably more in the compulsion category. Typical avoidance behaviors for OCD could be, just as I mentioned before, not touching the doorknob, trying to not be the last one to leave the house, so you can't be responsible for being the one who left the stove on, or if you have, for example, intrusive thoughts around fearing to be a pedophile, then you would avoid looking at children or getting close to children. And so all of those behaviors are meant to reduce some kind of distress that the intrusive thoughts cause. Um, there's some things that are not good for you that you might be avoiding, like, for example, going on Instagram first thing in the morning, opening your phone first thing in the morning, avoiding people that don't care for you or that make you feel bad about yourself. But as you see, like in the examples, it's usually those avoidance behaviors are very, very different from the avoidance behaviors you see in OCD. So you usually the best way to approach it, I guess, would be to ask yourself, what is my avoidance driven by? Am I feeling some kind of distress, some kind of doubt, some kind of uncertainty that the avoidance might relieve? Or do I think that the avoidance will help me to improve my overall well-being or learn some kind of new way to cope with certain situations? That makes any sense. Another question. I am 68 years old, struggled with OCD my entire life, even as a child, but did not come out of the closet about it until I was 30 years old. My faith is the most important thing to me, and I'm struggling with sexual unwanted thoughts about Jesus. It's hard for me to pray or study my Bible or have conversations about him without being tormented by these unwanted thoughts. Um, oh yeah, I remember that question. I actually, it was much longer than what I just read out. Um, because there were two parts of it. The person was describing their symptoms, and they were also asking for ways to find affordable help, which is not a question that I can answer generally in a way that it would be helpful for the people attending this Q&A. So that part actually our customer support is handling right now. But I also feel like there was some kind of like that person described their symptoms and how it affects them and how long they have been suffering from OCD. So I think there was also kind of this question of like, what am I going to do with the symptoms and what are your thoughts about that? So I'm going to relate to that. First of all, the fact that you're saying that you only came out of the closet about your OCD when you were 30, just know that you're not alone with that. For a lot of people, the time from the first onset of symptoms to the actual diagnosis and then to actual treatment is very, very long. I think the average was 11 years, if I remember correctly. First of all, because it can be difficult to diagnose. There's a lot of misdiagnoses, but also there can be shame around the topic. You might feel like that therapy won't help anyways. So there's a lot of reasons why it sometimes takes a long while. And no time is too late to actually treat your symptoms. So I think it's amazing that you're trying to find help. For those of you who have been to previous webinars of me, any webinar on OCD, probably I mentioned this thought at least once. No wonder that your OCD revolves around the idea of religion, because you mentioned how important it is to you, religion and your relationship with God. And OCD is a bully. It looks for what's important to you, and then that's where it's going to sit. So for you, OCD kind of intruded into your space where you pray, where you read the Bible, where you learn about the Word of God, because that's something that is of deep importance to you. Kind of the same way that, for example, a new mother can be tormented by thoughts of her hurting her baby, because obviously that's the center of the universe for a new mom. But just like those intrusive thoughts that a new mom might experience don't mean that she is a bad mother. It just means how important it is to her to be a good mom. In the same way, those intrusive thoughts don't mean that that faith is not important to you, that you don't respect God, that you are less of a believer. It just shows how important your faith is to you. So the key really is into kind of trying to cope with those thoughts without giving them importance. Those thoughts are not sent by the devil. They don't say anything about you. Um, you probably had this thought randomly come up, and then because it's very scary, because we relate to it, because we engage in compulsions, the thoughts come back again and again. So just know that this is very common. That's why scrupulosity, OCD is very common amongst religious people. It's you're not having those thoughts because you don't love God and you're less of a believer in your faith. It just shows you how important it is to you. And I know it's hard to kind of not relate to those thoughts because they can torment you, they can create great distress. But the more you learn to let them sit on your hand like a fly and just focus on whatever you were doing, reading the Word of God, praying, the easier it will get. It's really a question of practicing. Okay, next question. I constantly ask my girlfriend if she's mad at me, even when I know deep down she's not. I can't stop myself. How do I know when it's OCD talking and not just me being sensitive? Um, Wait, so you're basically saying deep down, I know she's not. That's a tricky question. Um, if you were saying, well, my girlfriend is one of those people who have a hard time expressing their emotions, specifically when it's anger. And there were situations where she actually was mad at me, but I didn't know or understand. I just noticed she was distant, and then I had to like figure it out by myself, blah blah blah. Those patterns, exist in relationships, and then you can, become a little bit hesitant or skeptic or lacking the right word, but it can become an issue that you ask yourself, well, is she mad at me? Or he, if it can also be the other way around, that you ask yourself this question more and more. However, this doesn't sound like this is your relationship pattern. Um, it sounds more like you are a person who is seeking 100% certainty in the fact that you're okay and that you didn't do anything wrong and that your girlfriend still loves you and that she is not mad at you for any reason, right? Um, and the thought, the fact that you need 100% certainty leads to thoughts like, is she mad at me? Did I do something wrong? To cause some level of distress because in fact you can never be 100% certain. And then you engage in those behaviors where you ask them or where you go through conversations mentally. Yeah, actually this person said, yeah, they outward ask their girlfriend, but there's also a lot of mental compulsions going on usually of like going through conversations, trying to look for signs of anger, trying to think whether there's anything you might have said or done that wasn't okay. And then those compulsions are actually the thing that maintains the cycle and makes the intrusive thoughts come up again and again. And they create this illusion that if I ask often enough, if I'm just cautious enough, if I really kind of think about every word that comes out of my mouth, then I can be 100% certain that I'm not doing anything wrong in the relationship. But actually, the opposite is true. Oftentimes, the reassurance seeking can become extremely annoying for the partner, and you become obsessed and preoccupied by this question instead of just enjoying the relationship. And I do have to say, I get it because kind of for some people, fighting or having another person be mad at you is just extremely hard to bear. For some people, the idea of being left, of the relationship taking a wrong turn is insanely frightening. So I get it. Like taking the risk of being in a relationship and the fact that it can go wrong and that it can get wrong at any point, and no commitment and no wedding vows can change that. That is always, in my opinion, um courageous, right? We make ourselves vulnerable, but this search for certainty, those reassurance seeking behaviors or checking behaviors, they will ruin your relationship, and you will never find out if it would have lasted or not. Okay, another question. That one, actually, I remember, I found it super interesting when it was submitted. Um, my OCD is telling me that everything in this world has value. How can you say OCD thoughts don't have value? Even dust can be from a rainbow. Even dust can form a rainbow. Everything is made by God, so everything has value. So OCD thoughts must also have value. So yeah, I found this question super interesting. I'm always excited when I kind of get confronted with a train of thought that I've never heard before. Also, I do want to disclose that I myself am not a religious person, but I do have a lot of respect for it, and I think there's a lot of beauty and spirituality and believing in God. Um, yeah, but there's just some thoughts that I wouldn't come up with. Um, so obviously there's some details missing in this question. Some things that I asked myself when I read it is that um, first of all, the person, or I hope you're here, whoever asked this question. First of all, you're saying that your OCD is telling you that everything in the world has value, and then you're saying, well, but God created everything, so it must have value. So it sounds like the idea of the fact that everything has value, at least in your mind, doesn't come from the OCD. It sounds like it comes from God, and I can kind of understand and respect that. It leaves me with the question, why is it OCD then? Like, because you're not mentioning your intrusive thoughts or your compulsions. Um, so that kind of knowledge is lacking. Then another question is like, you start the question like, my OCD is telling me that everything around has value. How can you say OCD thoughts don't have value? It kind of made me think that, like, did I say that? Because I don't think I would say that. Or did you just kind of assume that therapists or people who specialize in OCD assume that? That question is not so important. It just made me wonder. Um, I don't think personally that it makes a difference whether you believe that the intrusive thoughts have value or don't have value. I think the point is whether you think that the intrusive thoughts have meaning. And there I would be straightforward. I would straightforward say, no, they don't have meaning. They might have value. I mean, in this definition of everything having value, you would also say that a lie would have value. So I guess you could say that an intrusive thought can have some kind of value. I would say they don't have meaning, and they don't have to be true or related to reality. So An intrusive thought doesn't mean that you're going to do something, that you have a certain intention, that something is going to happen, or that something did happen in the past, or that it doesn't say anything about you being a bad person. Sometimes, as you heard when I talked about the religious OCD, it means it points towards something that is really important to you. So the meaning is basically whatever the OCD is torturing you about is a thing that is really important to you and that defines you. But the content of the intrusive thoughts don't have meaning. Our brain produces hundreds and thousands of thoughts every day. And you would be surprised how many of those are benign, meaningless, or even plain wrong. The intrusive thoughts don't stick because they are true. They stick because they scare you. So maybe that's also some kind of value. I mean, they do something with you. They cause distress. Yeah. So the question is not about value. It's about meaning, in my opinion. Another pre-submitted question. I go over conversations in my head again and again to make sure I didn't offend anyone. It feels like I have to be 100% sure. Is this reassurance seeking or something else? Um, that is actually a very common compulsion. I would not call this reassurance seeking. I would call this checking behavior, mental checking, a mental compulsion. Um, Basically, what happens is that usually we are afraid that in those conversations we might have offended someone or said something that was morally not okay. Or we go over conversations in our OCD and relationship OCD to figure out whether we love our partner or our partner loves us, or if the relationship is right. I'm sure there's more examples, but so this mental checking behavior can occur in different kinds of obsessions. Um, the problem is that let's say your intrusive thought is you talk to this person, maybe you have offended them, and then um, the compulsion, the acting on it, the going back into the conversation and analyzing it is sending a message to your brain of like, okay, I had the thought that there's a chance that this happened, and now I'm doing something about it, which means there's actual danger, right? There is an actual chance that I might have offended someone. So the behavior is giving the intrusive thought meaning. You're not pushing it away by like saying, okay, maybe I did, maybe I didn't. There's always a chance that you might offend someone without noticing, but I didn't do it intentionally. And if I haven't offended them and they are an adult, mature person, they're going to talk to me about it. I'm going to apologize, right? You're not putting aside you're thinking, oh, I might have offended them. And if I have to find out about it and I have to do something about it. And those are messages to your brain that will lead to the fact that if this intrusive thought comes up again, it will become even more distressing, and your brain will kind of eventually, in your brain, the option that you've actually offended someone will become will seem more and more likely. You will try to avoid all kinds of you'll try to eliminate this risk at all costs, and you might start going over conversations in more context or add more compulsions. And this is how OCD kind of um, finds way into your life, and the moment it's in your life it will spread, right? Okay. Oh, very good question, because it leads us to another topic that we haven't discussed yet. My husband wants me to leave the room whenever he's doing his rituals. And I've been doing that for years. Am I helping with that? Should I stop? So that would be not the most classical, but definitely an example of accommodation. And accommodation is so tricky. It's so tricky when your partner has OCD, or actually, it doesn't even matter if it's anxiety or depression. It's difficult. You want to support them, but some of the things that you feel might support them actually defeat the purpose. And this topic comes up a lot with parents who are obviously involved very much in their children's lives, usually, and also feel this responsibility to help their children solve their problems or solve them for them. And what I kind of want to bring across, the main point that I want to bring across in those situations is that if you have your loved person here and you have the problem they're coping with here, for example, in OCD, you would say your loved one, and then the OCD might be some kind of uncertainty that they're facing, some kind of risk that they have to take, for example, the risk of touching a doorknob and then coping with the very, very small chance of having maybe infected themselves with an illness. And when we accommodate, then it means that we are here in the middle between the problem that our loved one is coping with. We're trying to shield them from the problem, right? For example, we will tell them, no, 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 no way. Or if after they touch the doorknobs, they wash their hands, and then they will ask they will wash their hands, but then they say, well, but you've touched the doorknob, now you can't touch me unless you wash your hands as well. We do whatever we can so they don't have to deal with what they're supposed to be dealing with. But us standing in the middle causes a lot of problems. It can lead to dependence. It can lead to it usually doesn't work in the long run. And most importantly, it leads to the fact that they don't learn themselves to cope um, with their problems, which is like a really long introduction. When actually, in this example, it's a little bit like I just wanted you to have an idea of what accommodation usually looks like. In this case, it's a little bit more intricate because the partner is not really involved in the rituals. Um, but their life is limited by the rituals. They're supposed to do something, so their partner has an easier time doing the ritual, right? And you might think, okay, I'm going to give them privacy. I want to respect their space. But actually, what you're doing is you're helping with the rituals. You're making it more comfortable for your partner to perform their rituals. And usually, what I recommend is that a partner should not have to change anything about the way they behave or what they do for the OCD, not for the OCD. That's why we call it accommodation. You're accommodating the OCD, and you're not supposed to do that because you're feeding into it. You should not have to adjust your life to your partner's OCD. Okay, we have a question that was just submitted in the chat. I just don't know exactly what it's relating. I think it's relating to something that I said. So the question is, what about harm OCD? The fear that I will act on my thoughts against myself and go crazy. So I think you have to send a follow-up question of like, so what about the harm OCD? What is your question about it? Yeah, please send a follow-up question. I'm going to go to another pre-submitted one, and then I will relate to that one. but I'm not sure what the actual question is. Because I think you were relating to something I was just saying in the moment, and now I don't know what what I was saying anymore. Um, oh, another one. My teenage daughter insists I answer her text immediately with yes or no, or she gets really anxious. I want to help her calm down, but am I feeding the OCD by doing it? Okay, so that's another one about accommodation, and that's I would say a more classical one where the or maybe yeah, you could also call it reassurance seeking. I would put it more in the category of accommodation. Um, I think your daughter has a really hard time coping with the state of uncertainty. For example, asking a question and not immediately getting an answer. Um, and what you have to ask yourself as a parent is what's best for my child, right? What will help my child in the long run? In the long run, they will ask people questions, send them texts, and not get an answer right away, or they will not get a clear um, answer. So the ability to be able to cope with that is something that my child needs. If I always answer every text immediately with a clear yes or no, that first of all limits my life because it stresses me out and it makes me change my behavior for my daughter's OCD or yeah, daughter. Um, and also, um, it stops her or prevents her from learning to cope with uncertainty or cope with the fact that sometimes you have to wait for an answer. And as much as I do know that coping with teenage children is difficult and there might be a lot of resistance to it, but um, you know, your children learn how to relate to other people with you. You're kind of the subject, you're the learning model of how they will interact with other people. So, first of all, whatever you're doing, your behavioral patterns, that's how they consciously or consciously are going to expect other people to behave. And also, the way that you let them treat you might be the way that they intuitively treat other people. Obviously, it's not always black and white and not obvious that always that obvious, but your children learn how to be a social being, how to relate to others with you. And that's why you should think about it like setting boundaries is super important because other people will set boundaries for them. And if they don't learn to respect the boundary or cope with the frustration that comes from the boundary, then it will really negatively impact them later on. Okay, thank you so much. So the person who asked the question elaborated for further. So my harm OCD is the fear that I will hurt my own eyes. How do I learn to trust myself that I will not act on my thoughts? Um, that is a complicated question, and obviously, if anyway, this webinar is supposed to help people learn about OCD. It's not a form of treatment, right? But first of all, I will want to tell you that what we have here is what we call a thought action fusion. Okay, you think that the thought of stabbing your eye um, equals or might make the action more likely. That a thought and an action is fused, when in fact, in reality, oftentimes we have many thoughts about certain actions, and not all of those actions will happen. But wait, I'll jump back to that later. The most important part is a thought and an action are not directly connected. In between a thought and action, we at least need an intention. If you have the thought of hurting your eye, but no intention of doing it because it sounds like the thought makes you scared, right, or anxious, then you are not going to do it. That's not how the brain works. The thought alone doesn't do anything. You need to form an intention. And even if you have the intention, oftentimes we have a lot of intentions. We have the intentions to make it, to eat healthy, to not get angry so quickly, to take the stairs instead of the elevator. We have so many intentions, and then we still don't act on them, right? So until it comes to an actual action, a thought is not even remotely enough. What happens with those harm OCD thoughts is that the outcome is so insanely scary that we want to that even the slightest idea of a risk makes us so anxious that we want to do something against it. But having the thought of hurting your eye points in zero ways to any to the risk you have of hurting your eye. It just shows that you're really scared of the option. So that would be kind of the cognitive work that I would do in this situation. And then there's also the ERP part, the exposure with response prevention. So whatever rituals you are doing in terms of avoiding hurting your eyes, maybe you're sitting on your hands, maybe I don't know, what would I do to avoid hurting my eyes? You avoid taking sharp objects into your hands. You avoid getting your hands anywhere close to your eyes. Maybe you wear glasses, so you would have at least a barrier for your hands um, to reach your eyes. All of those things, stop doing them. And then you will not hurt your eyes, and your brain will learn that the risk that the intrusive thoughts or the OCD make you feel about hurting your eyes is not what actually happens. I had a client that had harm OCD where they were afraid of hurting themselves or their partner with a knife. And one of the interventions was that he had to practice cutting a salad with a really sharp knife next to her and just do it and like stick with the distress and the anxiety until it went down or until his brain had learned, okay, nothing's going to happen. Whatever the OCD is telling you to do the opposite. We have one last submitted question and we're already almost at an hour. Wow, okay. Can rituals shift from being behavioral to mental over time? For example, I used to wash my hands, but now I just mentally go through things I did to see whether I had any moments of contaminations. Yeah, so unfortunately, OCD is a very fluid thing that can change its shape and colors. You can have different obsessions. The OCD can jump from one obsession to the next. Very common if you, through ERP, for example, learn to let go of one compulsion, another one might come up. So it really is like a sticky thing that even once you've learned to cope with it, you constantly have to stay on it because it might raise its head with a different quality of thoughts or a different kind of rituals. It can creep in from all kinds of directions. this really reminds me of another client that I had, and she had like washing compulsions. But at some point she stopped, and she would only wash her hands once, but she would sing a certain song while washing her hands, where she would notice exactly, and the washing her hands would have specific steps. And by each step being connected to a part of the song, she would make sure that she hadn't forgotten about any part of any steps of the washing her hands. And so kind of the washing itself, like she washed her hands once, right? Like most hopefully normal people. But it was still ritualized in a mental way, not in a behavioral way anymore of washing your hands 10 times. And then, for example, with this specific client, we practiced leaving out steps of this washing structure, or singing a different song, or not singing a song at all. Obviously, also not washing your hands at all. Yeah, so absolutely compulsions can switch. When they switch from a behavioral compulsion to a mental one, it's always a little bit more tricky because the mental compulsions are um, harder to kind of catch and easier to miss. But yeah, you have to really watch out for the OCD, because it really tries to hold on to controlling your life in different ways. On the upside, to be a little bit more positive, if you've managed to do, for example, exposure with response prevention with one compulsion or several, and then a new one comes up, you already have the tools, you already know what to do, even if you're not in therapy anymore, right? Or idea of doing therapy, for example, ERP, is not that at the end of ERP, all compulsions have to have ended and the person is now OCD free forever. It means they have the tools to cope with OCD, with whatever remained from it, or if OCD comes back again, or if they have a relapse, they have the tools to cope, right? That's the goal. All right. I always feel like after those Q&A webinars that I've talked so much, I hope there was some helpful information in there for you. If any question might still come up even after the webinar, please feel free to send them to our customer support. They will forward them to me or to another expert. Thank you so much for joining. I hope I'll see you around for the next time, and have a great rest of your day wherever you are.